Good afternoon po, Doc.
Hello.
Good afternoon po.
Okay. Yan, naririnig ko kayo. Okay. Naririnig na ninyo ako? Do you hear me now?
Yes po, Doc.
Okay. Are you all in? All of you are 109?
Yes po, Doc.
Okay. Can you see my slideshow?
Doc, medyo maliit po siya. Parang naka-vertical po.
Paano? Wait lang ha. Francis, paano to? Medyo naka-vertical. Pwede ba siya? Palakahin.
Okay na po, Doc.
Yan, mas okay na ba yan?
Yes po, Doc.
Pero nakikita pa. Wait lang. Lang. Nagbabaw naman. Kaya. Wait lang ha, ayusin lang natin ito. Ayan. Okay, let's start. Okay, 107 kayong lahat?
Yes po, Doc.
Okay, sige. Nakikita nyo din ba ako? Hindi.
Yes po, Doc. Naka-on po yung cam.
Okay. Sige, on na lang natin para makita din. Sabihin ninyo pag hindi ninyo nakikita yung, kasi mag-represent ako ng whiteboard dito mamaya para makita din ninyo yung mga sinusulat ko. Okay? Okay. So our topic for today is advanced cardiac life support and basic life support. So also known as ACLS and BLS. By the way, I am Dr. Olive Nasis Ramos, an anesthesiologist, a pharmacist also. Okay. So first is, let's start with your medication that are being used during ACLS and BLS. So usually the route of administration for your resuscitation is ideally it should be intravenously or intraosseously. However, sometimes we have no IV access or IO access, so we can opt to give the drugs via ET tube. Okay? Pero if you cannot access any of the IV or intraosseous line. Okay, however, if the patient is already admitted, usually they have already central lines or IV lines, then you can give your medications via central lines, such as CVP or at the IG line. Okay? Next is, what are the medications that can be given via ET tube? So the examples are the Narcan, Atropine, Vasopressin, Epinephrine, Lidocaine. However, the dose of each drug should be doubled for about 2 to 0.5 times the normal dose. So, for example, if the computed dose is 1 milligram, then you can opt to double it. Okay? Para maging effective. Okay. So, let's start first the medications that are being used for cardiac arrest. We have two types. These are the pressor agents and the antidysrhythmic agents. So the pressor agents can increase blood flow, such as epinephrine and vasopressin. For antidysrhythmic drugs, they can suppress the dysrhythmia. Okay, examples are the amiodarone, lidocaine, and magnesium sulfate. Okay, may na-late pa. Okay. Examples of your pressor agents are the epinephrine. Epinephrine, the MOA of epinephrine, it stimulates adrenergic receptors. It causes positive inotrope, positive chronotrope, increase the systemic vascular resistance, hence increasing the BP, and it also increases the force of your contraction. And also, it will increase your coronary and cerebral blood flow. And usually, epinephrine is also added for asthmatic attack. So, because they also cause bronchial dilation. Okay, the indications of your epinephrine are for cardiac arrest, for symptomatic bradycardia, for severe hypotension, and also for anaphylaxis. Okay, if you have severe allergic reaction, you can give your epinephrine together with your fluid volume and corticosteroids and your antihistamines. Okay, the dosage for your epinephrine during cardiac arrest is 1 milligram at the dilution of 1 is to 10,000 every 3 minutes. Okay, at maximum dose of 0.2 milligrams per kilogram. If you're going to use it as infusion, you can regulate it at 2 to 10 micrograms per minute. If you're going to give it endotracheally, so you just double the dose, as what I have said before. Pwede rin, you can give subcutaneously and IM with a dose of 0.3 to 0.5 milligram. Okay, you have to remember, class, that higher doses of your epinephrine or more frequent doses do not increase survival and may contribute to myocardial dysfunction. Okay? Naririnig ninyo ako ha?
Yes,
Hello?
po.
Okay. Clear? Clear naman?
Yes, po.
So far? Okay. So the precautions that should be observed when giving epinephrine is if the patient has a myocardial ischemia, history of angina, and of course, if the patient has decreased oxygen level, kasi they increase the oxygen demand. Okay, so it will further aggravate your ischemia or angina or your oxygen demand. Okay, the next one is your vasopressin. Okay, your the MOA of your vasopressin, it causes vasoconstriction with reduced blood flow to the peripheral areas, increasing core perfusion during cardiac arrest. So the indication of your vasopressin is may pumasok ulit. Na late siya. Okay? So the indication for your vasopressin is it is used as an alternative to epinephrine. Okay? So what are the dosage of your vasopressin? It can be given as single dose at 40 units that replaces either the first or second dose of your epinephrine. Okay? And then after that, epinephrine can be resumed 3 minutes to 5 minutes after. It can also given endotracheal. Okay? So, the precautions of your vasopressin, you have to bear at your mind that it is a potent peripheral vasoconstrictor. So if the patient has blood supply problem at the peripheral area, it can aggravate the decrease in blood flow. For example, for patients with PAL, like that. And it can also increase demand upon resuscitation. Okay? Back tayo. Back tayo. Okay. Next is your antidysrhythmic drugs, such as your amiodarone and lidocaine. Okay. First, antidysrhythmic drugs that we usually give during resuscitation is your amiodarone. The MOA, it prolongs myocardial cell action potential, duration, and refractory period by direct action on all cardiac tissues, hence decreasing the AV and SA conduction rates. Okay. So the indication is for ventricular tachycardia with pulse. Okay. It can also use in ventricular fibrillation and pulseless VTAC. And also for patients who are unresponsive to epinephrine during CPR, and for patients who are not responding to any shock, and also for patients who are not responding to any vasopressin. Okay, the dosage for your amiodarone for VTAC with pulse, it should be given at 150 milligrams IV over 10 minutes and may repeat every 10 minutes as needed. However, for ventricular fibrillation and pulseless VTAC or ventricular tachycardia, you can give initially at 300 milligrams IV or IO flush with 20 ml plain NSS, and then you can follow another dose of 150 milligrams after 3 to 5 minutes if needed. Okay? So the precautions that should be observed, amiodarone can cause bradycardia, okay, and can even cause second and third degree block. So, and also you have to be precautious in giving this amiodarone in patients who are taking procainamide, kasi they have they cause prolonged QT interval. Okay. Next one. The next one is lidocaine. So the MOA of your lidocaine, it decreases depolarization, atomicity, and excitability of your ventricle during diastole by direct action and reversing ventricular dysrhythmias. Okay. It is indicated for stable monomorphic ventricular tachycardia and also for malignant premature ventricular contractions, okay, for PVCs. So the dosage of your lidocaine is 0.5 to 0.75 milligram per kilogram at up to 1 to 1.5 milligram per kilogram, and it can be repeated as necessary at low range lang to a total dose of 3 milligrams per kilograms. If you're going to use infusion, you can regulate your lidocaine at 1 to 4 milligram per minute. Okay. Again, the precautions. It should be the dose should be reduced for patients who have impaired liver function. Okay, kasi they cause systemic toxicity and may further aggravate your liver injury. Okay, it is contraindicated for prophylactic use in patients who have acute myocardial infarction. Okay. Next one is the medications for your bradycardia. We have atropine, epinephrine, and dopamine. Okay, first is the atropine. It inhibits the actions of your acetylcholine on structures innervated by your postganglionic sites, such as your smooth cardiac muscles and SA and AV nodes. It is indicated for symptomatic sinus bradycardia and also for organophosphate poisoning. Okay, the dosage is 0.5 milligram every 3 to 5 minutes at maximum dose of 3 milligrams. It should be you should have precautions on patients who have MI or myocardial infarction and hypoxia. Okay, it should be avoided in patients who are hypothermic, and you have to see to it that the lowest dose to be given is 0.5 milligram and above. If lower than that, it may cause paradoxical slowing. It may even cause bradycardia if mas mababa dyan yung dose na ibibigay ninyo. Okay? You have to remember that. So again, the other drug for your bradycardia is epinephrine, as we already have discussed that. However, during bradycardia, it is advisable to give your epinephrine via infusion at the rate of 2 to 10 microgram per minute. Okay? And the third one, wait lang, naghahangin. The third one is your dopamine infusion. It is a precursor of your norepinephrine that stimulates dopaminergic receptors in those dependent fashion. So it is indicated in severe symptomatic bradycardia and can be, it is usually used after atropine. Okay, you can also use during hypotension with bradycardia. Okay, the dosage is 2 to 20 micrograms per kilogram per minute. Okay, precautions. You have to correct first your hypovolemia or underlying cause of your hypotension before initializing your first dose of dopamine. Okay? Kung hypovolemic yung pasyente, you have to give hydration. If the patient is in septic shock, you have to treat it first before giving your dopamine. Okay? You have to use it cautiously with cardiogenic shock and associated CHF. Okay? Because they can cause tachydysrhythmias and excessive vasoconstriction. Okay? Wait. Yeah. Next one is the medications for your tachycardia. We have the adenosine, amiodarone, and lidocaine. Okay? The first is your adenosine, which slows impulse formation in the SA node. It slows conduction time through AV node, hence depressing the left ventricular function and restores normal sinus rhythm. Okay, it is the drug of choice for stable, narrow, complex SVT or supraventricular tachycardia. Okay. The side effects are flushing, bradycardia, and even asystole. Okay, the dosage for your adenosine is 6 milligrams IV, rapidly given, followed by 20 ml normal saline flush, and then elevate the IV site. Okay, and then you can repeat the dose at 12 milligram every 1 to 2 minutes if unsuccessful yung resuscitation mo. Okay? Next one is your amiodarone. Okay lang ba kayo? Okay pa kayo,
Yes po.
class? Okay. The next one for tachycardia is your amiodarone. It prolongs myocardial cell action potential, duration, and refractory period by direct action on all cardiac tissues. It also decreases AV and SA conduction rate. It is indicated for ventricular tachycardia with pulse. Okay, you can use amiodarone for ventricular fibrillation or pulseless ventricular tachycardia if your shock is not enough or the patient is unresponsive. Okay, then if the CPR is not enough also. Okay, so epinephrine, after epinephrine, if the patient is unresponsive, then you can give amiodarone for the next treatment for arrest. Okay, makikita ninyo mamaya. So the dosage for ventricular tachycardia with pulse is 150 milligrams IV over 10 minutes. It can be repeated every 10 minutes as needed kung hindi pa nare-revive yung pasyente. Okay? And then if the patient has VFib or pulseless VTAC, you can give initially with 300 milligrams IV or IO, flush with 20 ml plain NSS. By the way, class, lahat ng mga IV drugs natin during ACLS and BLS, it should be flushed with 20 ml plain NSS, and then the IV site should be elevated para makapunta kaagad sa heart yung drug mo, and then it will function kung ano yung gusto mong i-function. Okay? Kung ano yung gusto mong ma-achieve. Okay? Okay. And after your 300 milligrams IV, you can follow it with one dose of 150 milligrams IV after 3 minutes to 5 minutes as needed lang. Kung hindi pa rin talaga na-revive yung pasyente. Okay? And the last one is your lidocaine. Again, it decreases depolarization, automaticity, and excitability of your ventricle during diastole, reversing your ventricular dysrhythmias. And the dosage is, again, it's 0.5 to 0.75 milligram per kilogram up to 1 to 1.5 milligram per kilogram. Okay? Okay. So, tapos na tayo sa medications during resuscitation. Okay. Naintindihan ba? Did you understand, class?
Yes po.
Okay. Okay. To summarize it all, for you to understand it more, I will just review you about the autonomic nervous system. Okay? Para mas maintindihan ninyo kung ano talaga yung mechanism of action of all the drugs that I have discussed. Okay? Para mas maintindihan. Diba, tapos na kayo na first year, second year. So, alam na ninyo yung autonomic nervous system? Or medyo natabunan na? Hello? 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 May kausap ba ako? Do you hear me?
Yes po, Doc.
Okay. We will just review about your ANS for you to appreciate more the mechanism of actions of the drugs that can be used during ACLS and BLS. Okay? Para mas may view kayo ulit. Kung alam na ninyo, we will just review. Okay? Can you see my whiteboard?
Yes po, Doc.
Okay. So, we have your ANS, autonomic nervous system. Can you see it?
Yes po.
Okay. So, we have two branches of your ANS. You have your sympathetic and your parasympathetic. Remember? And then 3 branch is yung bago ngayon, the GIT, pero wag na nating ikon yan. Wag na nating i-discuss yan. We will just simplify it for you to understand and appreciate all the MOAs of your drugs that are being discussed, okay? So for sympathetic, it is also known as your what? Hello? Hi! Nagahang ba ako sa inyo? Nagahang ba yung...
Hindi naman po. Hindi
Hindi
naman po.
Okay. Okay, your sympathetic nervous system is also known as your fight or flight, di ba? Okay. Very good, Miss Marcos. Okay, it is also known as your fight or flight. And for your parasympathetic is your read. Ayan, okay. Or read. Ginagawa ko read para lang mas madali kong i-recall. Or you can opt to go for rest and digest. Okay? Okay. Okay, bakit sila tinawag na fight or flight and read or rest and digest? Okay, so first, we have to know first your receptors responsible for your sympathetic. You have the alpha, we have the alpha 1 and 2, the beta 1 and 2, and the dopamine 1 and 2. Okay? So under ng sympathetic ang mga ito, alpha, beta, and dopamine. Okay, remember that. And then for your parasympathetic, we have the receptors such as your nicotinic receptors 1 and 2 and your muscarinic 1 and 2. Okay? O, maliwanag yan, di ba? Okay. So ngayon, what are the things that you can feel, or what are the symptoms that you can feel if you stimulate your sympathetic? Ano yung, sige, signs, or kung ano yung mararamdaman mo kung in-stimulate mo ang sympathetic? Wala. Anyone? Okay. O ito, imagine. Okay, increase heart rate. Very good. Dr. Marcos. Okay. So kaya siya, that's why it is also known as fight or flight. Because you use your sympathetic during calamities, if you are nervous, or you need to save your life in case of emergency. Okay? Okay, so ano bang nararamdaman mo? What do you feel if you are in panic or you have for example dito sa sea, malapit tayo sa sea, di ba? Sa dagupan. So for example, you saw a tsunami. So anong okay? Correct? Dr. Sam John, okay? Pupil dilatation. Okay, ano pa? What do you feel if you see a big tsunami coming to you? Class, diba, you're going to run. Okay? So if you run, anong magiging reaction ng heart mo? Is the heart rate will increase or decrease?
Increase po.
Increase. Tachycardia. Tama, Dr. Ballesteros. So, tachycardia. Okay? You just imagine yourself, you fight or flight. That's why it's used for running. Okay? Kasi you feel increase in heart rate. Imagine mo, you're running, so you increase your heart rate. So what else? For you to save your life from drowning on that big tsunami. Ano class? Pupil dilatation, tama. For you to see from afar, malayo pa lang nakikita mo na kung saan ka dadaan. Okay? Bronchodilation, tama. Because you need more oxygen for you to run, for you to have more energy to save yourself. Okay? That's why you have to bronchodilate. What else? Increase alertness. Pwede? What else? Are you going to increase your RR? Your respiratory rate? Yes, di ba? Yes, okay. Okay? During sympathetic, remember, you need more oxygen for you to have more energy to save yourself. Kasi you have to run for your life. Okay? Okay? This, I am just simplifying it for you to remember, even if after your third year or fourth year, or even if you are already consultant. Okay? Okay? So you need more oxygen to save yourself. So how are you going to increase your oxygen? So increase your heart rate. Okay. If you increase your heart rate, your BP will also be increased. Okay. So how are you going to increase your oxygen? So increase your cardiac return via decreasing your SVR. Okay. Okay. What else are you going to do? You bronchodilate for you to increase again your oxygen. What else? You increase your RR, your respiratory rate. Okay? So, if you increase this, then you have more oxygen, you have more energy to run. Okay? And then your pupils will be dilated. You just imagine. Faster depletion after you save your life. Pero during sympathetic stimulation, increase pa rin lahat yan. Okay? Bakit? Mayroon bang nanghina habang tumatakbo at sinisave niya yung life niya? Wala, di ba? Unless mayroon kang cardiac problem. Okay? Okay, what else? Are you going to pee? Iihi ka ba during tumatakbo? No. Pupupo ka ba? Are you going to defecate? No then, because your sphincters are constricted, but your GIT motility is decreased. Okay? Your urethral sphincter is also constricted, and your bladder muscle is relaxed. Okay? Are you going to eat habang tumatakbo ka? No, di ba? So, okay. Kasi you have to save your life again. So, yung esophageal sphincter mo is constricted also. Okay. Mouth dryness. Okay. So, naintindihan ba to? Naintindihan ba yung sympathetic? And next is your parasympathetic. It is also known as your read, rest, and digest. So imagine yourself. You're just sitting there reading your book. So no need for more oxygen. No need for more energy. Kasi nagre-relax ka lang doon. Okay? Okay? So your pupils are constricted kasi nandito ka lang, nagre-read ka lang. Okay, tama. Diba? Pupil constriction. Kasi hindi mo naman, may nagbabasa bang sobrang layo? Wala, di ba? So, it's just near you. So, you just constrict your pupils. And then, while you are sitting, you can just eat kasi your esophageal sphincter is relaxed. While you are resting, you can pee and poop. Kasi all your sphincters are relaxed and your GIT motility are increased. Okay? Naintindihan? Do you need more oxygen? No. Kasi umuupo ka lang. So, no need for dilatation of your bronchus. So, you have your bronchoconstriction. Okay? Do you need more blood or more cardiac output? No. So, your heart rate is decreased. Also, your BP decreased then. However, your SVR, your systemic vascular resistance, is increased. Okay? Naintindihan? Naintindihan ba, class?
Yes,
That? Okay. So, mas naintindihan na ngayon ang difference ng sympathetic versus your parasympathetic. Okay. Ngayon, now, what are the drugs that we use to increase your heart rate? Okay, epinephrine. Epinephrine. Okay? Ano bang MOA ng epinephrine? It is a non-selective alpha and beta agonist. So, saan ba yung alpha and beta? Nandito sa sympathetic. So, it will cause increased heart rate, increased BP, and bronchodilation. That's why it is being used during asthma attack or anaphylaxis because of that MOA. They cause bronchodilation and anti-shallow din. Kasi nagkukos siya ng mouth dryness, di ba? Sabi natin kanina. Okay. What else? Ano pa? Yung atropine, saan siya? Is it here or here? Sa sympathetic or parasympathetic? Anticholinergic. Tama. They are anti-muscarinic drug. Okay? Anti-muscarinic drug. Remember, class, this is, the ANS is like a fulcrum. Okay? This is the sympathetic, the parasympathetic. Okay? If you enhance this will predominate. Okay? If you inhibit this will predominate. That's why your atropine is anti-muscarinic. So, ininhibit mo yung muscarinic receptor. Ininhibit mo yung parasympathetic. That's why your sympathetic predominates. Kaya mo na kukuha yung increased heart rate. Increased heart rate lang kasi it is a specific for muscarinic antagonism lang. Okay? Kaya increased heart rate lang. But somehow, indirectly, it will increase also your BP. Pero the main mechanism is to increase your heart rate. Okay. Naintindihan ba? Naintindihan na yung ANS and parasympathetic, ay sympathetic and parasympathetic? Diba? Easier na. You can imagine na if you have a patient who is bradycardic or atropine. If the patient is bradycardic with hypotension, you can give epinephrine. Okay? If the patient has anaphylaxis or hirap huminga, then you can give your epinephrine together with your antihistamines and fluid volume. Okay? Tapos na tayo doon. Maliwanag na sa sympathetic and parasympathetic. Okay, how about your lidocaine, your amiodarone? Ano bang, diba, they are usually used for anti-arrhythmia. Okay? So let's just discuss. Mabilis lang. Yung action potential. Yan, hindi ko alam mag-drop. So you have your phase 1, phase 2, phase 3, phase 4. Okay? So this is the action potential, depolarization. Okay? This is the usual kung ano yung nangyayari during depolarization. Okay? So pag may stimulus, if you have stimulus, then the sodium and potassium will exchange. Okay? Remember, ito muna, ano yung physiologic na area ng potassium? Is it inside your cell or outside your cell? Inside your cell. So remember the piso. Okay? Potassium in, sodium out. Okay? So this is the physiologic area of your electrolytes. So once you have an influx and efflux of these electrolytes, then you will have your action potential and depolarization will occur. Okay? And then you have your refractory period here. Dito, until here, this is the absolute time that the automaticity will the muscle will not be stimulated. Okay, that's why for lidocaine, amiodarone, what else? Yung mga anti-arrhythmic drugs. Okay, especially for lidocaine. Lidocaine decreases sodium entry. Okay, so kung wala kang pumasok na sodium, then wala kang potassium na lalabas. Then wala kang depolarization na mangyayari. So, if you have arrhythmia, the heart will restart again kasi magpapahinga yung heart mo dito eh. Okay? And then, the dysrhythmia will be reversed. Naintindihan? Maliwanag ba? Medyo maliwanag ba or medyo malabo? Hello? Tulog na ba kayo? Okay. So yun. Yun yung simplified paliwanag kung paano yung MOA ng iyong lidocaine, especially your lidocaine. Okay? Okay. Pagtapos na tayo sa drugs. May class pa ba kayo after 3 p.m.?
Meron po to. May word breaks po yung ibang groups.
Hello?
Hello po to. May word breaks po yung others.
Ano na?
Yes po to. May class po later 3 p.m.
Okay. Just, anong time na?
No, it's 1:45 po right now.
Okay. Or just remind me if it's already 3 p.m. ha?
Yes po to.
Okay. So, okay. Any question sa medications? Medyo mas maliwanag na ba ngayon ang about sa sympathetic drugs and parasympathetic drugs and your antiarrhythmic drugs? Okay. Okay. So let's now go to your Acls and Bls. So what are the components of your Acls and Bls? So initially, the approach is you have to check first the consciousness of your patient, the breathing of your patient, and the color of the patient. Okay? Okay. Some other algorithm, they advise to check first the safety of your patient, your safety, and the safety, yung safety din ng place. Okay? Kasi sometimes, some patients arrested due to poisoning or due to bombing, ganon. So you have to remove first the patient from that area for you to protect the patient and also yourself. whenever you do resuscitation. Okay? Okay. So, ito. So, initially, you have to check your consciousness and the consciousness of your patient. For example, you have seen a patient collapse while you are walking, going to LNU. So, what are you going to do? Are you going to run? Are you going to remove your uniform as medical student? Or are you going to help? Of course, tutulong kayo, di ba? Kasi konsensya naman, di ba? So, the first thing that you should do is check for the consciousness of your patient. So, what are you going to do? So, you have to check, you tap. For example, this is the patient, this is the head. You just tap the shoulders, okay? You have to ask the patient, hey, are you okay? Hey, are you all right? Bilateral ha, kasi some patients are deaf. So you have to check on both sides for them to hear it if the patient is conscious, okay? Then if the patient is unconscious, you go to BLS. If the patient is conscious, you go to ACLS. Okay, while you are tapping the patient, you are assessing also the breathing of your patient and the color of the patient. Okay, if the patient is gasping or not. If the patient is breathing normally or not breathing at all. And also the color of the patient, you have to check for the lips. If the patient has cyanotic lips or not. Is it pinkish or not? Okay? Then, yun na nga. If the patient is conscious, ACLS. Unconscious, BLS. Okay. For ACLS, you do your primary assessment and then your secondary assessment. So, this is the systematic approach, ha? Okay. So, next is, this is the Acls survey. Okay. You have to initially visualize the patient. Yun na nga, pinaliwanag ko. You have to check for the consciousness, the breathing, and the color of your patient. Okay? The next V is, you check for the vital signs and then you ask the patient, verbalize. So remember this class, the VOMIT, okay, vomit. So for you to do your ACLS, you just follow this one. You have to visualize. So checking the consciousness, the breathing of your patient, the color of the skin and the lips, and then check for the pulses. So how are you going to check your pulse? At your carotid area, you just measure 2 finger breaths from your carotid area here at the side of your neck, and then that's the carotid, and then you just assess it from up to 5 seconds. 5 seconds to 10 seconds lang ha, wag na kayong tatagal. The ideal time for you to assess for the pulse at the carotid area is up to 10 seconds only, for you to know if the patient has pulse or not. Okay? Okay. If you have your your BP apparatus at your bag, inside your bag, you can opt to get the BP if the patient has pulses, or if the patient is inside the hospital, you can do all the vital signs. That should be that should be assessed, okay? And then verbalize. You ask the patient, are you okay? Are you all right? Mayroon ka bang masakit? Masakit ba ang dibdib mo? May masakit ba sa'yo? Nahihirapan ka bang huminga? If the patient can verbalize all his complaints, then it's easy for you to help him, okay? However, if the patient is not able to verbalize all his pains or all his needs, then you need to do all the physical examination. And also, syempre, yun nga, vital sign. And then, next one to do is check for the oxygen. So, if the patient is desaturating, then give oxygen. And then if you have available monitors, then hook the patient to monitors, like ECG. And then next one is insert an IV line or intraosseous line. And then if the patient needs to be treated, then give treatment. Okay? So remember the VOMIT, vomit. Okay? Next one, for initial impression, then visualize. Okay, again, visualize consciousness, breathing, and color. And then for primary assessment, you get your vital signs. So you have to do your ABCDE. Check for the airway if it is clear and patent. Okay. Sometimes patients have obstruction, then you have to address that. Okay. And also, you have to check for the work of breathing. Is the patient gasping or not? And then for the respiratory rate, what is the normal RR, by the way? Class? Okay, 12 to 20. Okay, for adult. By the way, our discussion is for adult. ACLS and BLS for adult only, ha? Okay, separated ang pang-ped yan. Okay. Okay, tama. Thank you, doctor. So, the normal RR is 12 to 20. Okay, cycles per minute. Okay, if more than that, you have to address it. Okay, and then next one is to check for your O2 saturation. The cutoff for O2 saturation for healthy patient is 94 and above. Lesser than that, you should give oxygenation. And also, you have to check for the breath sounds. You have to auscultate. If the patient has crackles or wheezes, then you can address it. Okay. Next one is your C, which is circulation. You have to check for the heart rate. The normal heart rate is, again, may late, super late. Ngayon lang pumasok. Okay, tama. Thank you, doctor. Okay, 60 to 100 beats per minute. Okay? For the BP, how about the BP? What's the normal BP? Okay, less than 90/60 is hypotensive. Okay, tama. Okay. 90/60 and above dapat. Okay, that's the normal BP. Below that is hypotensive. Okay, naintindihan? And then the next one to assess is your central and peripheral pulses. So for the central, you have to check for the heart rate. If you cannot hear the heart rate, you have to check your carotid area. However, during ACLS, the ideal to check for your pulses is your carotid area kasi it's easier, okay, and more accessible, okay. And then remember, you just assess the pulse rate as fast as you can, as fast as 5 to 10 seconds for you to revive the patient. Kasi pag mas maaga kang nagbigay ng treatment or the faster you give your CPR, the patient may survive. Okay? Pag late ka na, pwedeng mamatay yung patient. Okay? And then you have also to check for the capillary refill time. Okay? How are you going to check for the capillary refill time? You just pinch the nail bed. Dapat yung pink nawawala and then pag inalis mo, nagiging red. So healthy yan. Pero pag inalis mo at white pa rin or black, hindi bumalik yung pinkish, then the patient is cyanotic or may problema yung pasyente. Okay? And then, for you to give fluids or any drugs, you have to insert your IV or intraosseous line. Okay? And then, when the monitors are coming through, you can opt to hook the patient to cardiac monitor. Okay? For the D, you have to check for the disability of your patient through your Glasgow Coma Scale and your AFPO, alertness, verbal, pain, and ano yung what? Basta yun, yung AFPO. Tapos yung FAST, yung facial asymmetry, arm weakness, or slurred speech. Those are the signs of stroke. And also, you have to check the glucose of your patient. Some patients are being unconscious due to hypoglycemia only. So you have to check also. Okay? And lastly, for the E, is the exposure. Okay? Is the patient bleeding? Or is the patient has fracture or trauma? Victim ba siya ng burns? Or is the patient a medical patient? So you check for the bracelet. Some patients who have seizure disorder, cancer, or cardiac problems have medical IDs. So you have to check also, okay? For you to know, for you to assess the patient properly, okay? Okay. And then, after the primary assessment, you go to the secondary assessment. So how are you going to ask for secondary assessment? So you just, this is, for example, yung patient is conscious talaga. Kasi nasa ACLS tayo, di ba? Conscious na. So, you ask the patient kung mayroon ba siyang sakit, any signs and symptoms before, any allergies, any medications she is taking, any past medical history. If the patient has diabetes mellitus, hypertension, or allergies like those. And also you have to check or ask the last meal. And also the events before the the collapse or dizziness. Okay? Pwede ninyong tanungin, kailan ka ba huling kumain? Yun. Or napagod po ba kayo? Baka naman tumakbo siya ng malayo kaya nag-hypoglycemia siya. Okay? Okay? So, for the secondary assessment, you have to just do the sample, SAMPLE, for you to remember it. Okay? For S, signs and symptoms, allergies, medications, past medical history, last meal, and the events prior the dizziness or kung ano yung nangyari sa pasyente. Okay? Okay. So, tapos na tayo sa V, di ba? For the V, okay, you check for visualize, okay, get the vital signs, and then verbalize. You ask the patient. Next one is oxygenate. So, after checking your O2 sat, if the O2 saturation of your patient is less than 94%, then you can give 2 to 4 LPM if you have nasal cannula only. If the available if the available equipment in the hospital is your face mask only, then you can give your oxygen at 6 to 10 LPM. For non-rebreather mask, you can give 11 to 15 LPM. Okay? Remember, class, you can only use your nasal cannula at 2 to 4 LPM, not greater than that. Kasi imagine ninyo, yung nasal cannula, yung nasal prong nakaganon sa ilong ng pasyente, and then pag nilakasan mo yung oxygen, para siyang nalulunod and magdra-dry yung nostrils ng pasyente. Okay? Imbis na maka-help ka, na aggravate pa yung problema ng pasyente. Okay? And then for the M, you have to monitor. If the monitors are already available, then hook the patient to monitors. Okay, such as your ECGs. Okay, if your ECG monitor is monophasic, you have the leads such as white, black, red. Okay, yung mga leads niya na nandito, yun yung mga colors. So the white color should be hooked at the white right, black left, may L, red green. Okay? If the cardiac monitor is biphasic, which is colored red, yellow, green, you have to hook your red lead at your right. Yellow, again, may L, left. Green, dito. Or just remember, for monophasic, if you have fire, red, you have two smokes, the white at the right, black at the left. Okay, for biphasic, you have a plant, the green leaves, and you have two flowers, which are the red for the right and the yellow flower at the left. Okay, naintindihan? Para hindi ninyo makakalimutan. Ang tendency kasi, pag nandun na kayo sa pasyente or nagpapanik na kayo, hindi na ninyo ma-recall kung ano na yung dapat gawin. Okay? Nandyan pa ba kayo, class?
Yes po.
Okay. Medyo matagal tong ACLS and BLS. Okay? Pero, I think this is very useful. Okay? Okay, next one is you have to insert your intravenous or intraosseous line. Okay? How are you going to establish your vascular access? So, ang pinaka-ideal para mas mabilis kang makakuha ng IV line mo, you do your intravenous line at your antecubital veins. Okay? Dito. Kikita ba ninyo? Dito or dito? Okay? Kasi this is the biggest vein so far sa peripheral natin na accessible. Okay? So you just insert your IV line here. If you cannot access your IV line, then you can opt to do your intraosseous line. So the site of insertion is at the humeral head of your body of your patient, at the sternum, at the proximal tibia of the patient, or distal malleolus. Okay? Parang ganito. Kunwari, ito yung leg ng pasyente. Ito yung shin niya. Nandyan yun. Ito yung parang buto na yung proximal tibia. Then you just palpate it and then puncture it. Okay? Ganyan lang. Parang ito yung needle, gaganan lang ninyo dyan. Tapos yun na yung IV line ninyo. Intraosseous line is usually done sa mga pasyentes na media or maliliit na patients pag wala silang linya. So very late si Dr. Sakla. Okay, and lastly, for your VOMIT is you have to treat. After surveying your patient or assessing your patient, if the patient needs treatment, then you give treatment. Okay? Okay, so ngayon, punta na tayo sa usual treatment during ACLS. Okay? But first, we have to review the normal sinus rhythm. Okay? So, under normal conditions, wait muna. May questions ba kayo? Dun sa diniscuss natin. So, may questions? Wala. Wala naman. Or nakatulog na kayo. Basta, none. Okay, none. Okay. Sige. Okay. For okay, thank you, Dr. Ballesteros and Dr. Alvarez. Okay. Under normal conditions, the sinoatrial node or SA node in the atria sets the pace for the heart. So, siya yung talagang unang-unang nagbibigay ng signal. And these impulses travel down to the ventricles through your atrioventricular node or also known as your AV node. Okay? Si AV node, siya yung taga-regulate ng lahat ng itatapon ni SA node para si ventricle na sasalo lahat ng signal ay hindi malito at hindi ma-overwhelm. Okay? Para yung heart mo is normal to contract. Okay? Naintindihan? So remember, for the ECG tracing, your P wave corresponds to your atrial contractions. For your QRS complex, corresponds to your ventricular contraction. Okay? Alam na ninyo to. Okay, nire-review lang natin. So, the encircled picture is the ECG tracing of your normal sinus rhythm. So, you have your P wave, QRS complex, and then P wave. Okay? Yan yung normal ECG. Para lang malaman natin. Ngayon, whenever you have the abnormality of your heart, you can see Brady Arrhythmia, Tachyarrhythmia, or any abnormality of heart contraction. So first is we will discuss about Brady Arrhythmia. Okay, bradycardia is the heart is where the heart rate is less than 60 beats per minute. So pag 59 bradycardic na yan. Okay, it is usually caused by conditions such as sinus bradyarrhythmia, sinoatrial block, and atrioventricular block. Okay. So for AV blocks, is the wherein the conduction between the atria and ventricles of the heart is impaired. Okay, so ito na. Pag nagkaroon na ng hindi pagkakaunawaan si AV node and SA node, nagkakaroon na ng impairment dun sa contraction ng heart. Kaya nagkakaroon ka na ng abnormality. Okay? The electrical signal does not reach the ventricles or is impaired along the way. Okay, the ventricles of the heart have their own pacing mechanisms which can maintain a lowered heart rate in the absence of SA stimulation. Okay, so AV blocks are considered as bradycardia, bradyarrhythmia. Okay, so what are the causes of your AV blocks? It can be due to ischemia, infarction, fibrosis, drugs, or even can appear in some children and athletes. And usually they are benign or normal variants. Okay? Pwedeng normal siya sa mga sporty na tao. As long as asymptomatic yung pasyente and stable. So, what are the kinds of your AV blocks? We have the first degree AV block. The heart's electrical signals move between the upper and lower chambers of the heart. So, normally, your PR interval is just 0.2, 0.20 seconds and below. Pero pag sa first degree AV block, it is greater than 0.20 seconds, yung PR interval mo. Okay? Most of the patients are asymptomatic and no treatment is needed. Okay? Ito yung picture ng first degree heart block. So as you can see, the PR interval is longer or greater than 0.20 seconds. Nakikita ba ninyo, class, yung P wave, yung P and R, mas malayo, di ba? As kumpara dito sa normal sinus rhythm. Okay? Mas malayo. So, yan yung first degree heart block. Okay. For the second degree AV block, type 1, also known as Wenckebach periodicity or Mobitz 1. The heart's electrical signals between the upper and lower signals of the heart are slowed by a much greater rate than in first degree atrioventricular block. It is characterized by an increasing delay of AV nodal conduction until a P wave fails to conduct through the AV node. This is seen as progressive PR interval prolongation with each beat until a P wave is not conducted. Okay? Causing a drop beats. Okay? Nagkakaroon ka ng drop beats. Nawawala na lang bigla yung P wave mo. Kunwari, ito yung P wave mo, no, normal muna, tas papahaba siya ng papahaba, hanggang wala na siyang P wave. So that's the drop beats. Also known as first degree AV block type 1. Okay? So this is the picture of your second degree heart block type 1. So as you can see, malapit pa yung PR interval nung una. Dun sa second QRS, PQRS, malapit pa, di ba? Tapos yung sumunod, mas malayo na. Tapos yung pangatlo, mas malayo na until wala ka nang makitang P-wave. Okay? And QRS. Wala ka ng QRS. Wala na. That's the drop beat. Naintindihan? So, some patients with type 1 second degree AV block are asymptomatic. And only those who are symptomatic respond to treatment effectively. So, kung asymptomatic, no treatment. Okay? Pero kung symptomatic and unstable, then give treatment. Okay? There is low risk of AV block leading to heart attack. Okay? Medyo safe ka pa dito ng konti. Next one is the second degree AV block type 2, also known as Hay periodicity or Mobitz 2. Okay? The His-Purkinje cells are responsible for the rapid electrical conduction in the ventricles, relaying electrical impulses from the AV node to the muscles and thus coordinate the contraction of ventricles to ensure proper cardiac pump function. Second degree AV block is characterized by a failure of His-Purkinje cells resulting in the lack of supraventricular impulse. So for example, ito yung heart mo. Yan. Andito si SA node. Andito si AV node. Siya ngayong nagre-regulate, di ba? Yan. Pupunta yung impulse mo dyan through your His-Purkinje. Okay? Pag pumunta na yung signal, yung impulse mo, si muscles ng heart magkocontract. Okay? For Mobitz 2 or second degree AV block type 2, ito yung abnormal mo. Okay? So kung normal pero abnormal naman ito, paano siya magkakaroon ng coordinated cardiac pump? So wala. Magkakaroon ka talaga ng second degree AV block. Okay? It is usually characterized by unexpected non-conducted atrial impulse without prior measurable lengthening of the conduction time. You have a constant PR intervals wherein the P waves may be followed by a QRS complex, giving the ECG a normal appearance. Then the next P wave may suddenly not be followed by a QRS complex due to non-conduction of signals from AV node to ventricles. Siyempre, di ba? Kaya wala na tayong QRS kasi ito yung abnormal nga. So, paano ka magkakaroon ng QRS? Kasi nga, di ba nga sabi natin yung QRS is your ventricular contraction. Okay? So, hindi na magpo-contract yan. Kaya wala ka ng QRS. Bigla ka na lang mawawalan ng QRS. Okay? Intindihan? So, it is usually more serious than type 1 and will sometimes require pacing. Okay? Ito na yung kailangan mo nang magbigay ng pacemaker. Okay? Kung walang permanent, then yung temporary muna. Okay? So, this is the picture of your type 2 second degree AV block. So, as you can see, you have your normal PQRS, constant PR interval, and then wala ka ng QRS. Okay? Naintindihan? So what's the difference between the type 1 and type 2? For type 1, you have the delay or subsequent prolongation of your PR interval. So may normal, tapos lumuluwag hanggang nawala na. Okay? Wala ka ng tracing. So yun yung drop beats. Pag sa type 2 second degree AV block, normal lang yung PR interval mo, normal. Bigla na lang nawala, walang pasabi-sabi. Okay? Yun yung second degree type 2. So, the risk and possible effects of your MOBITS 2 are much more severe than MOBITS 1 in that it can lead to severe heart attack. So, medyo tagilid ka na dito pag mayroon kang second degree AV block type 2. So, treatment is usually given initially with intravenous pacing until a permanent pacemaker is placed. Ito talaga yung kailangan mo na talaga ng pacemaker agad-agad na. Kasi kung hindi, magkakaroon ka ng severe heart attack. Mamamatay ka agad yung pasyente. Okay? Okay. The third degree AV block, it is also known as a complete heart block. It is a medical condition in which the nerve impulse generated in the sinoatrial node or SA node in the atrium of the heart does not propagate to the ventricles. Okay? So, yung diniscuss natin dito, di ba yung type 2, dito yung problema. Sa kanya, wala na talaga. Ito na talaga. Okay? So, complete heart block na. Okay? Because the impulse is blocked, an accessory pacemaker in the lower chambers will typically activate the ventricles. This is known as escape rhythm. Since this accessory pacemaker also activates independently of the impulse generated on the SA node, two independent rhythms can be noted on the ECG. So, labo-labo na talaga. So, since hindi nagpo-function yung AV node mo, yung mga dapat na mag-function, kailangan niyang mag-survive. So, kung saan-saan na siya kumukuha ng pang-stimulate niya. So, kung saan-saan na yung nagko-contract. Walang coordination. So, the treatment requires agad-agad talaga. Temporary or permanent pacemaker. Okay? So, ito yung itsura ng third degree heart block. So, as you can see, labo-labo. You cannot appreciate, hindi mo na alam, lumuwag yung PR interval, normal yung PR interval, you have no definite QRS, and then wala kang QRS like those. Okay? Kasi you have a complete disruption of AV conduction. Okay? Usually yung mga pasyenteng ito, pag hindi agad-agad nabigyan ng pacemaker, namamatay sila due to heart attack. Okay. So now, what are the treatment for your Brady arrhythmia? Again, if the patient is asymptomatic and stable, you just observe. Okay, observe lang. Except for the second degree type 2 AV block and your yung third degree AV block, diba? Kailangan mo talaga ng pacemaker doon. Okay, next. If the patient is symptomatic and unstable, you have to treat. Okay? Remember that. So, how are you going to treat? Okay? If the patient is symptomatic and unstable, you have to treat. Remember the ATDE. ATDE. Yan, acronym na yan para pag nagpapanik ka nare-recall mo. Okay? For atropine sulfate, you can give 0.5 milligram, as we have discussed before, at maximum dose of 3 milligrams and total dose of 6 doses with an interval of every 3 to 5 minutes. Okay? Naintindihan? Pag hindi pa rin effective, hindi pa rin nag-increase ang heart rate, then you can give your dopamine infusion. Okay? Dopamine infusion at 2 to 20 micrograms per kilogram per minute. Okay? Pag wala pa rin, you can opt to give your epinephrine infusion. Okay? Titrate the dose to patient response. Okay? Initially, you can give 2 micrograms per minute at maximum dose of 10 micrograms per minute. Okay? Kapag hindi pa rin effective, tapos na si ADE, then you can opt to insert or give your patient under transcutaneous pacing. So, yun lang. Maglalagay ka ng pacer dito. Ito, temporary lang. Pero, if you have permanent pacemaker, then you can insert. Okay? For the patient's welfare din. Okay? Naintindihan? So, again, pag yung Brady Arrhythmia is asymptomatic and the patient is stable, what is the treatment?
Observe po.
Observe. What if it's symptomatic? If the patient is symptomatic and unstable, you just memorize your 4 ATD. Okay? Atropine, transcutaneous pacing, dopamine, and epinephrine. Tigi isa-isa lang, huwag mong pagsasabayin yan, ha? Okay? Una, atropine. Yan yung ideal drug for your Brady Arrhythmia. Pag hindi effective, then go to your dopamine. Pag hindi pa rin effective, stop. Go to shift to epinephrine. Pag hindi pa rin effective, go to transcutaneous pacing. Unless second degree type 2 ka and third degree type 2 ka, pumunta ka na kaagad sa transcutaneous pacing. Okay? Naintindihan? Okay. Now, let's go to tachyarrhythmia. So, tachyarrhythmia or tachycardia is observed if your heart rate is more than 100 beats per minute. Kasi diba, sabi natin, the normal heart rate is 60 to 100 beats per minute. Okay. So, tachyarrhythmia includes SBT, or also known as supraventricular tachycardia, and VT, which is ventricular tachycardia. Okay. First is we discuss your SVT, or supraventricular tachycardia. It is a narrow, complex, and has no P wave and narrow QRS. Okay? Maliit lang siya. Wala kang P wave. Well, cute lang siya. Si SVT. Okay? Yan. Nakikita ninyo yung encircled na picture. Okay? You have your heart rhythm abnormally fast, arising from improper electrical activity in the upper part of the heart. So, okay. Next one is, okay. So, let's go to the treatment of your SVT. So, you have to check first if the patient is stable or unstable. So, sabi natin, di ba, ang BP, the normal BP is 90/60 and above. If lower than that, the patient is unstable. Okay, if the patient's BP is 89/59, then the patient is considered unstable. If 90/60 and above, stable siya. So what are the treatment? You go first for physiologic treatment. Okay? What are you going to do for physiologic treatment? You do your vagal maneuver. So, we have 2 maneuvers to do your vagal stimulation. So, do your carotid massage. But, you have to bear in your mind that you just do your carotid massage for patients who are young and no risk of thrombosis or embolism. Okay? Pag yung patient is more than 45 years old na, don't do carotid massage. Okay? Or the patient has history of embolism, don't do carotid massage. Okay? What you can do is, you ask the patient to cough or strain if the patient is more than 45 years old. Okay? So, yung dalawa na vagal maneuver is carotid massage. And then, next one is cuff or strain. Okay? If your vagal maneuver is not effective or your physiologic treatment is not effective, then give your pharmacologic treatment. So, you can give your adenosine rapidly via IV bolus, initially at dose of 6 milligrams. And then flush it with 20 ml plain NSS and then elevate the IV site. And then if still not effective, you can give the second dose at 12 milligrams IV. Flush with 20 ml plain NSS and then elevate. Okay? However, if the patient goes to unstable site, okay, the patient's BP is now 80/60, then you can opt to do your synchronized cardioversion. However, at ACLS, the patient is conscious, di ba? Naintindihan? Class? The patient is conscious. You cannot do synchronized cardioversion if the patient is conscious. Kahit na sino, pag kinuryente ka na gising ka, baka uumbagin ka ng pasyente. Okay? You have to sedate first the patient before you do your synchronized cardioversion. Kasi, hello, ang sakit-sakit kayang makuryente. Okay? So how are you going to do your sedation? You can give diazepam, midazolam, etomidate, propofol. Those are sedative hypnotics. By the way, midazolam and diazepam are benzodiazepine or barbiturates. Hello? Wala na ba? Okay, bilisan na lang natin. Yes. Very good, Dr. San John. They are benzodiazepines. Okay? So they can also cause amnesia. Okay? So, at least hindi matatandaan ng pasyente na kinuryente mo siya. Okay? Okay. If you're going to do your synchronized cardioversion, you have to do it at R-wave. Diba? Mayroon kang ECG tracing. QRS. Yung QRS. R ito. Yun yung R. If the ECG tracing is already at the R, then you give your synchronized cardioversion. That's the time you're going to press the synchronized cardioversion. Okay? At energy dose of 50 joules initially, and then going up until 360. Okay? Until the patient is cardioverted to normal sinus rhythm. Okay? Naintindihan? So, SVT. So, for SVT, you have to check if the patient is unstable or stable. If stable, you do physiologic first. If not effective, pharmacologic. If the patient is unstable, then you do synchronized cardioversion. But firstly, you have to sedate your patient muna. Okay, before doing your cardioversion. Okay? Next one is your ventricular tachycardia or VTAC. Okay? Your ECG tracing has a wide complex, no P-wave, wide QRS. So matataba. Okay? Remember, your SVT maliliit. Adenosine. Yan yung SVT. Okay? Para hindi ninyo makalimutan. Adenosine. Okay? Pag VTAC naman, if you have your VTAC, matataba. Amiodarone. Okay? So, naintindihan ba, class? For you to recall it easily, amiodarone, mataba ang tracing. Pag VTAC, amiodarone ang drug of choice. Pag SVT, payat ang tracing, adenosine ang drug of choice. Okay? Naintindihan? So for your Vita, it is the type of regular and fast heart rate that arises from improper electrical activity in the ventricles of the heart. Okay? For the treatment of your Vita or ventricular tachycardia, and the patient has pulse, remember, you're still at your ACLS. The patient is conscious, the patient has pulse. Okay? Okay, you have to classify first your patient if the patient is stable or unstable. Again, you have to get your BP. Okay, if the BP is 90/60 and above, then give pharmacologic treatment, which is the Amiodarone. Okay, yung sinabi ko sa inyo, pag mataba ang tracing, Amiodarone. Okay, initial dose is 150 milligrams IV. Then flush it with 20 ml plain NSS and then elevate the IV site. The duration should be 10 minutes. Okay? And then, if the patient is now unstable, which is less than 90/60, you do your synchronized cardioversion. At yun again, sa R, pag nasa R yung tracing ng ECG mo, doon ka magsisynchronize cardioversion. But first, you have to sedate your patient using your diazepam, midazolam, etomidate, and propofol. We usually give midazolam 1 milligram IV para lang magkaroon ng amnesia and the patient will sleep. Okay? So, for the synchronized cardioversion of your Vita with pulse, we give 100 joules initially and then pataas ng pataas until the patient will be cardioverted. Okay? Naintindihan ba? Naintindihan, class? Maliwanag ba?
Yes po.
Okay, medyo maliwanag. What is the drug of choice of your Vita with pulse? Mr. Dr. Sino ba? Dr. Chunduri. Akash, what is your drug of choice for your Vita with pulse? Wala? You didn't understand, class? It's easy, di ba? Anyone? Yes, Amiodarone. No question mark. Diba? Sabi ko nga sa inyo, you have your two kinds of tachyarrhythmia. Okay? The Vita with pulse and the SVT. For SVT, maliit ang ECG tracing, adenosine ang iyong ibibigay. Okay? For for your Vita with pulse, maluluwag, malalaki ang ang QRS niya. So, Amiodarone. Okay? Naintindihan? Okay. Again, we go to the systematic approach of your resuscitation. So, initially, you have to assess the consciousness, breathing, and color of your patient. And then, if the patient is conscious, ACLS. And then, if the patient is unconscious, BLS. Okay? Now, when you have a patient who is unconscious, then you do your basic life support. Okay. Naintindihan? No, the patient is unconscious, no pulse. Pagka-check mo na ganyan, no pulse. And then you check, hey, are you okay? Hey, are you all right? No response. So you do your BLS again. Okay? How are you going to do your BLS? So, after checking the consciousness of your patient while assessing the breathing and the color of your patient, okay, you do your survey. So, while checking for the responsiveness, pag na-check mo, walang unconscious yung patient, you can opt to get help. You ask somebody to get defibrillator or AED. Okay? Or you just ask help. Kasi you cannot do the CPR on your own. You will be exhausted and the patient may die. If you're exhausted. Kasi hindi mo siya masi-CPR. Okay? Okay? And then, after asking for help, yun na nga, check for breathing and pulse simultaneously for 5 to 10 seconds. So while you are checking for the pulse, you are also looking at the chest rise. Kung walang chest rise, hindi humihinga yung pasyente. So, you do your BLS agad. Okay? So, you start your high-quality cardiopulmonary resuscitation agad-agad, as soon as possible, for you to save the life of your patient. Okay? So, how are you going to do your high-quality cardiopulmonary resuscitation? The characteristics of which is, you have to push hard at 2 to 2.4 inches or 5 to 6 cms deep. Huwag yung gumaganon-ganon lang kayo, ganyan lang, hindi pwede. Okay? You have to see to it that you give or you push hard at 2 to 2.4 inches. Okay? And then you have to push fast at 100 to 120 compressions per minute. Do you imagine yourself doing all the 100 to 120 compressions per minute all by yourself? Diba? Exhausted ka na after that. Okay? So you need someone to help you. Okay? Before starting your CPR, you have to ask someone to help you. Okay? And then, you have to allow complete chest recoil. Hindi naman yung ganyan ka lang ng ganyan. Hindi pwede. Okay? And then, the arm should be like that. Diretso. Nakikita ba ninyo? Hindi pwede yung ganyan. Okay? Ganyan. Okay? And then, for example, I have this. For example, this is the patient. So, the sternum is here. This is the xiphoid. You just put your hand there at the, if you cannot see the nipple, then you just palpate the xiphoid and then you push it there. Okay? You do your CPR there. Okay? Or in between your nipple line. Pwede rin. Okay? Hindi pwedeng dito, hindi pwedeng dito, hindi pwedeng dito. Here. At the xiphoid level, here. Okay? And then push it like that. Not like that. Kasi you have to give, you have to push as deep as 2 to 2.4 inches. Okay? And also, you have to minimize interruptions. Interruption should not be longer than 10 seconds. Okay? Avoid excessive ventilation. So, hindi pwedeng habang nagsi-CPR sila, bag ka naman ng bag. Hindi rin pwede. Okay? The compression ventilation ratio is 30:2. 30 pump to ventilation. So, 1, 2, 3, 4, 29, 30. And then ventilate 2. 1 ventilation and then count up to 5. 1, 2, 1,001, 1,002, 1,003, 1,004, 1,005. Another ventilation. And then after that, you resume your CPR. Okay? Again, you do your 100 to 120 compressions per minute. Okay? Okay. Naintindihan ba? Class, so far, medyo maliwanag ba or malabo? And what's yes po daw? Maliwanag? Clear or no? Clear. Okay. So once you panalo, okay. Anong panalo? Panalo ba yung CPR? Okay, basta na explanation. Okay, okay. Mabuti naman. Okay. So once your monitor is already has already arrived, then you can hook your patient to ECG monitors. Okay? Basta, di ba, once you have checked the pulses and then you ask for the help and then you started CPR once you have noticed that your patient has no pulse, not breathing and unconscious, and then after 5 minutes, the help already has arrived. Then hook the patient to monitors and then check for the rhythms. Okay. Once you have checked for the rhythms, is the patient's ECG rhythm is normal or abnormal? Okay. If the rhythms are abnormal, then you have to identify it. Is it shockable or non-shockable? Okay? For shockable arrest rhythms, we have three. Three lang. Okay? We have ventricular fibrillation, atrial flutter, and then your pulseless ventricular tachycardia. Okay, remember, yung kanina, di ba, we have the ventricular tachycardia with pulse. But now, for your shockable arrest rhythm, ventricular tachycardia without pulse. Okay, that's why it is very important for you to check for the pulses before doing all the treatment. Okay? Okay. So first, for the ventricular fibrillation, the heart quivers instead of pumping due to disorganized electrical activity in the ventricles. The diagnosis is by an ECG showing irregular unformed QRS complex without any clear P waves. Okay? So, through ECG talaga. So, hindi mo pwedeng i-diagnose via kapakapa lang. Kailangan mo ng ECG monitor talaga para ma-check mo kung shockable ka ba or not. Okay? This is an example of ventricular fibrillation, ECG tracing. So, wala kang P-wave, hindi mo maintindihan kung saan na. So, this is shockable, people. Okay? And next one, shockable rhythm is your atrial flutter. The atria depolarized in an organized circular movement. So, yung heart mo, gumaganon-ganon lang, pero hindi nagpo-pump. Okay, so walang cardiac output. So, walang pulses na nagagawa yung body ng patient. Walang blood supply. So, talagang mag-a-arrest. Mamamatay siya. Kasi gumaganon-ganon lang siya. So, sobrang bilis niya. Parang gumaganon-ganon. Okay? This is caused by re-entry. The atria contract typically at around 300 beats per minute, which results in the fast sequence of P wave. So imaginein mo 300 na gumaganon-ganon siya. So hindi na maintindihan ni ventricle kung anong gagawin niya. So kaganyan na lang siya. Parang tao din na pag nalilito na gumaganon-ganon na lang. Okay? The ECG pattern of your atrial flutter is sawtooth. Okay? This is what the ECG tracing looks like for your atrial flutter, sawtooth. So parang talagang yung pang saw, yung ngipin ng saw, or so ikita ninyo. Okay. So kung ganito yung ECG tracing, you have no cardiac output and usually you have no pulse. Okay. The last one for your shockable rhythm is your pulseless ventricular tachycardia. Okay? Again, sinasabi ko na para hindi kayo nalilito. Vita pulseless. You have white complex, no P wave, white QRS, but without pulse. Okay, without pulse. You have your heart rate, which is regular and fast. That arises from the improper electrical activity in the ventricles of the heart. However, the patient has no pulse. Okay, this is the ECG tracing again. You still have the white QRS, but when you check your pulses, wala kang pulse. That's the difference between the VTAC with pulse, which is you give your amiodarone, as opposed to VTAC without pulse, you do shock. Okay? That's the shockable rhythm. Pag VTAC without pulse. Okay. Okay, this is what are you going to do during shockable arrest rhythm. So you do, once you have checked the patient has no pulse, and then you have checked once you have checked the patient has no pulse, then you do your BLS, diba? CPR kaagad. While waiting for the Ecg monitor. Once you have hooked the patient at Ecg monitor and you have assessed that the rhythm is shockable, then give your shock at 360 joules if your shocking equipment is monophasic. If it's biphasic, 200 joules. Usually here in the Philippines, we commonly have monophasic, which is 360 joules. Okay? Lagay mo kaagad sa 360 and then shock. But before you do the shock, you have to see to it that no one is attached to the patient. The nurse, your colleague, or you yourself is not leaning to the patient. Kasi pag tinuryente mo yung pasyente at nakalean ka towards the patient, makukuryente ka din. So, baka dalawa na kayong isi-CPR. Okay? So, you have to check. You have to ask the team. I'm shocking in 3, 2, 1. You have to check. Clear, all clear. Clear to myself. Clear yung mga colleagues. Clear yung anyone. And then, you have to check the rhythm. If it's still shockable, then you give your monophasic shock. Okay? After shocking, then resume CPR. After doing CPR in 2 minutes, you have to do your SAS, stop, assess, and switch roles. Okay? So you have to stop. You have to look at the monitor if it's still shockable or already have revived, or the patient has already pulses. Ganon. You have to check also here. Then, if it's still shockable, then switch roles. Si yung nagsi-CPR and the airway or the one who is giving the drug will switch roles. Kasi to prevent exhaustion. Okay? And then after SAS or stopping assessment and then switching roles, then you do your shock again if the tracing is still shockable. And then after that, CPR again. And then if the patient is still not revived, then you can give epinephrine, 1 milligram IV or intraosseous, and then flush it with 20cc plain NSS, and then elevate the IV site. And then while you are doing your high quality CPR, okay, don't give any drug if the patient, if you are not doing CPR. Kasi imagine mo, wala ngang pulse yung pasyente, paano pupunta sa heart yung drug? Yung goal mo is pumunta sa heart para mag-pump yung heart. Okay? So you have to give all your drugs during arrest. You have to give all your drugs during CPR pag mayroon kang arrest. Okay? And then after giving your epinephrine, after 2 minutes of doing CPR, then stop again, assess, and then switch roles again. Okay? If still not converted, then do again the shock. Then after that, CPR, and then switch roles. And then you can now give your amiodarone. Yan yung sinasabi natin. Pag hindi effective yung epinephrine na, you can alternate it with amiodarone. And then after that, do CPR. And then after 2 minutes, do the SAS. And then if still not converted, then do the shock, CPR again, and then SAS after 2 minutes, and then you can give now again your epinephrine. Okay? Ganun na naman. Ito na naman yung algorithm. Again, you repeat the algorithm. Okay? Naintindihan? Okay. So, what are again the shockable arrest rhythms? We have the VFib. Ano mo class? VFib, VTAC Pulseless, and your Atrial Flutter. Oy, sumagot naman kayo para mabilis lang. O, sige. Wala pa namang alas 3.
Yes po, it's only 2:52.
Okay, o bibilisan na lang natin. Okay, so the next one is the non-shockable arrest rhythms. Okay, you have 2. Okay, for non-shockable. For shockable, you have 3. Fib, VTAC Pulseless, and your Atrial Flutter. For non-shockable, you have 2. Huh? Okay. For your non-shockable arrest rhythm, you have asystole and your pulseless electrical activity, or PEA. If you have any organized rhythm on your ECG tracing and yet you cannot appreciate any pulse, then that's PEA. Okay? Mayroon kang ECG tracing, mayroon kang P-wave ka, may QRS ka, ganon. Pero pag check mo dito sa carotid, wala namang pulses. So, PEA yung pasyente. Then, that's a non-shockable arrest rhythm. So, how are you going to treat your non-shockable arrest rhythm? Siyempre, hindi mo siya-shock. Okay? You just do your high-quality CPR, and then after while you are giving your high-quality CPR, you can give your epinephrine, the same dose, 1 milligram IV or intraosseous, and then flush with 20 ml plain NSS, and then elevate the IV site, and then you can give every 3 to 5 minutes. So after 2 minutes of your CPR, then you can stop, assess, and switch roles. And then after that, CPR again, kung still non-shockable. Okay? What if pumuntang shockable arrest rhythm yung pasyente? Pag-check mo sa ECG tracing, VF naman na, ventricular fibrillation. What are you going to do? Are you going to give your high-quality CPR na kaagad? Yun lang, plain lang? Or are you going to give your shock? Give your shock. Cardioversion. Okay? So, you have to give shock. Okay? And then, again, the rhythm, you go to the algorithm of your shockable arrest rhythm. Okay? Pero kung pumunta siya PEA again, and then you go to non-shockable arrest rhythm algorithm. Okay? Ganun lang. Kaya, it is very important for you to know the basic of CPR, to know the difference between the shockable and non-shockable arrest rhythm for you to manage your patient very well. Okay? So, while you are doing your CPR or reviving your patient, you are now thinking for the reversible causes of your cardiac arrest. So, isipin mo, ano bang possible na nag-cause ng cardiac arrest ng pasyenteng ito? For you to manage it while you are doing your CPR. Okay? To treat the underlying cause of the arrest. Okay? What are the most reversible causes of your cardiac arrest? Remember the 5H and the 5Ts. Okay? For the 5H, you have your hypovolemia, hypoxia, hydrogen ion acidosis, hypo or hyperkalemia, and then hypothermia. Okay? So, napansin ba ninyo? Hypothermia. So, nakakamatay pala talaga ang hypothermia. So, you have to think of it. Every time you have a patient, if the patient is hypothermic, then you have to put some blankets. You have to warm the patient kasi nakamamatay yan. Okay? And then for the 5Ts, you have your tension pneumothorax, tamponade, toxins, thrombosis pulmonary, and thrombosis coronary. Okay? How are you going to check while you are doing your CPR? Para mabilis, di ba sabi natin, you have to do all of those as fast as you can. all the assessment, all the diagnosis, all the treatment as fast as you can. Okay? You have to check while you are doing your CPR, you check for the lips. Is the patient lips cyanotic or not? If cyanotic, maybe the cause of your arrest is hypoxia. Okay. Is the patient's mouth has foul smelling liquid coming out from his mouth? Maybe maybe the cause is toxins. Okay, so naalis mo na yon, di ba? Then, next one, you have to check for the throat. You have to check for the trachea. If the trachea is deviated, baka nagtatamponad yung pasyente while you are checking for the carotid artery. If the carotid artery is bulging, then maybe the patient has tamponad. Or if the trachea is deviated, maybe the patient has tension pneumothorax. Okay? And then, while you are checking for the pulse, pag yung may bruit dun sa carotid artery, maybe the patient has thrombosis. Okay? So, na-rule out mo na yon while you are assessing your patient. And then, next one, you have to check for the abdomen. You can now check while you are checking for the pulses, you can check for the temperature of your patient, if the patient is hypothermic or not. And then, yung hypovolemia, you can check the skin. If the patient's skin is wrinkled or the lips of your patient is dry, then the patient maybe is hypovolemic. Okay? The things that you can just check at laboratory is the hydrogen ion acidosis and the hypohyperkalemia. Okay? So lahat na yun, yung 8 na yun, pwede pa-assess while you are doing your survey. Okay? Naintindihan? Check mo at when you do your PE, di ba? Head to toe. So, head, lips, trachea, deviated, tension yung carotid, bulging. Naririnig niyo pa ba ako?
Bumalik po kayo, na-disconnect po kayo ng sabihin.
Okay. Okay na ngayon? Narinig niyo yung last?
Yes
Okay.
po.
Paano ako? Wala na yung PowerPoint ko.
Doc, share screen po ulit.
Aha. Ayan, yan pala. Okay. Wait lang ha.
Sorry po, Doc. I think it's already 3 p.m. po.
3 p.m. na. Wait lang ha. Tingnan ko lang kung saan tayo nag-last. Mas naintindihan ba, class?
Yes po, Doc.
Medyo may kwan naman. Para mas makatulong kayo sa ibang tao, you have to study this very well para ma-apply ninyo sa practice ninyo as a doctor. Wait lang ha, hahanapin natin kung saan yung last slide. So again, what are the 5H and 5Ts? So for you not to memorize it, you just do the head to toe. Lips, cyanosis, dry lips, so hypovolemia and hypoxia. Okay? With toxins, foul-smelling liquid or foul-smelling breath, like that. Then trachea is deviated, rule in your tension pneumothorax, bulging carotid artery, rule in your tamponade. Then if you have bruit on your carotid area, rule in your thrombosis. And then if the patient is cold, rule in your hypothermia. And if you have identified those reversible causes of your arrest, then you have to treat it. You have to reverse it. Okay? Nandito na tayo sa ROS. Malapit na tayo. Konting-konti na lang, okay lang? Ay. Sige. Pwede rin naman, okay na yon. Ito na lang, ROS. Okay lang sa inyo? Ito na lang, return of spontaneous circulation. So, once you have revived the patient, once you have the pulses, so na-revive mo yung patient, then you do your ABCD. So, how are you going to do? Your airway, you have to check for the respiratory rate and the SpO2 of your patient. If the respiratory rate is 6 or the patient is gasping, then you need to insert an advanced airway. Okay? Or if the patient has no spontaneous breathing, then intubate the patient. So the primary confirmation of tracheal intubation is your 5 points of auscultation. How are you going to do it? You have to check first your epigastric. So 1, and then you have to check the gastric bubbles. If no gastric bubbles, then you have a high chance of inserting your tube at the lungs, at the trachea. So, okay? Kasi, bakit epigastric una? Kasi mas mabilis na marinig yung gastric bubbles. Kung may marinig ka ng gastric bubbles, then extubate the patient and then re-intubate. Okay? So, for example, you have checked your epigastric area and no gastric bubbles, then you check your base of your lungs. So, bilateral yan, ha? So, 1, 2, 3, 4, 5 at the apex. Okay? It should be equal. Okay? The secondary confirmation of your airway is through looking at your waveform capnography. So, yun yung monitor sa operating room or sa ICU na nag-identify ng CO2 level ng pasyente. Siyempre, pag may CO2 level yung pasyente at least two consecutive capnographic waveform, then you are inserted at the right place, at the trachea. Okay? So, the ventilation rate for your magbabag ka, the breathing should be 1 breath every 6 seconds to maintain EtCO2 of 35 to 40 millimeter Hg. Okay? So, yung difference kanina, nung nagsi-CPR kayo, 30:2. So, 30 CPR, 2 ventilation. Okay? So, at least 5 seconds na apart yung ventilation. The difference with your return of spontaneous circulation, pag meron ka ng pulse, pwede mo na siyang iba every 6 seconds. Okay? So, bag 1,001, 1,002, 1,003, 1,004, 1,005, 1,006. Bag again. Okay? Kasi okay na siya na i-ventilate. Pero yung kanina, hindi pwedeng i-ventilate mo ng i-ventilate. Okay? Okay. And then, next one is, you have to check for the circulation of the patient. Even if you have your pulses, you still have to monitor for the circulation of your patient. You have to check for the heart rate. Is the heart rate normal or tachycardic or bradycardic? And then, you have to check your BP. Is the BP unstable or stable? If it's unstable or hypotensive, then you can give hydration at 1 to 2 liters plain NSS or plain RS. IV bolus. Okay? Fast drip yan. Naibibigay mo yung 1 to 2 liters. Unless mayroon kang CHF or cardiac tamponade, you cannot give your bolus, IV bolus. kasi mas malulunod yung pasyente. And also, if the patient has crackles, you cannot give IV bolus. So what are you going to do? You can give dopamine infusion at 2 to 20 micrograms per kilogram per minute, or epinephrine infusion at 2 to 10 micrograms per minute, or 0.1 to 0.5 milligram per kilogram per minute. Okay? So, again, pag unstable yung patient, hydrate first before giving your pressor, dopamine and epinephrine. However, if you have crackles and CHF or tamponade, you cannot give your hydration. You go agad-agad sa dopamine or epinephrine infusion. Okay? Until the patient will be stabilized. Okay? And then for the D, which is the temperature and the Glasgow Coma scale of your patient, you have to check the GCS of your patient. If the patient is comatose, then you do your targeted temperature management. You can give 30 ml per kilogram of cold, 40 degrees, plain NSS or plain RS, IV bolus to run for 30 minutes. Okay, again, you cannot give this one if your patient has CHF or tamponade or crackles. Okay, your goal for the targeted temperature management, the core body temperature should be 32 to 36 degrees Celsius for at least 24 hours. Okay, after that, if the patient is already the GCS of your patient is already going up, then you can opt to stop the targeted temperature management. Okay, for post-arrest care, once the patient is already stabilized, then you can do your post-arrest care. So you, excuse me, you have to remember the sign of the cross. Okay, so NGT, you give your NGT, and then IFC. So nasogastric tube, insert nasogastric tube, and then for the IFC, indwelling Foley catheter, and then hook the patient to 12-lead ECG, and then do portable chest X-ray, and if needed, you can insert CBP. Okay, after doing those, the sign of the cross, you can transfer now the patient. If the patient has a STEMI or ST elevation MI, you can refer the patient to cath lab, okay, for the MI to be addressed. And if the patient has non-STEMI or non-ST elevation MI, you can just transfer the patient to ICU and refer it to an intensivist. Okay? Yun lang. So, again, the components of systematic approach is initial impression. You have to check the safety of your patient, your safety, and the safety of the buong paligid. Okay? So, once you have secured environment and your health is secured also, then you can assess the consciousness, the breathing, and color of the patient. The patient is conscious, do ACLS. The patient is unconscious, no pulse, BLS. Okay? So you just review this. The last slide is just the summary of all the things that we have discussed. Naintindihan? Hello? Okay na, thank you.
Thank you.
Naintindihan ba? Do you have any question? So are you ready to save many lives, doctors? Okay, naintindihan ha? So our next meeting would be, kailan na ba yun, Dr. Elijah?
No, November 17 and 18 for the
Thank you,
make-out
Dr.
class po.
Ha?
No, yung make-out class po natin sa 17 and 18.
Okay, 17 and 18. 17 would be the Lidocaine, local anesthesia lecture, and then 18 would be pain management. And then on Monday, we're going to have siguro group or individual na lang. Individual. I will just inform you. Individual activity, either pain management or ACLS. Okay? Okay, thank you also. I hope you understood, and I hope I have imparted some for your future practice. Okay, did you understand, people? Okay. Okay, thank you, and good afternoon. Hi, Dr. Elijah, can
Yes,
you get the attendance of all the students and then send it to my uh, Yahoo Mail?
Doc, si Doc Prime po nagko-collect na attendance since he owns the Zoom
Okay.
po.
Mayroon na yon. Okay,
Yes po.
okay. Okay. Sige. Okay na. Okay, see you on 17. Remind me, Elijah, okay?
Yes po.
Okay, salamat. Bye-bye.